Hello, I'm Minfan, and I will present our approach to clinical decision support system on behalf of my collaborators from the Hospital for Sick Children and University of Toronto. Electronic health records have been transformative to clinical practice, as they enable computational support for clinical reasoning and decision-making. Paradoxically, this data-rich environment have also resulted in clinical decision support tools that fit poorly into clinical contexts. The many displays, constant alarms, and complex interfaces are factors why this system increases healthcare workers' cognitive load. We propose a normal approach where the system curates data views relevant to the clinician's context by utilizing clinical problem as a basis for data exploration. Essentially, our approach combines the power of checklist, a rigorous, systematic, and reliable way of going over a list of potential problems in patients, and the power of interactive visualization dashboards to support analysis of rich, multivariable patient data. By integrating this into a cohesive clinical decision support system, we aim to support three goals. First, facilitating problem-based discovery. We propose to organize relevant patient information around patient problems instead of leaving it to clinicians to spend time and cognitive efforts to retrieve and integrate this data. Second, reinforce team communication. The system should provide a shared reference across the multidisciplinary healthcare team, capturing the knowledge about the patient and share the clinical goals. Then, situational awareness of patient problems. Coordinated team activity requires to retrieve the status of any patient at a glance in order to maintain team performance and reduce errors. We explore our approach in the context of a pediatric intensive care unit, where critically ill children need close monitoring. In our context, the clinical team must check the fluids that the patient intakes and the fluid out, which is a prevalent procedure to every critically ill patient and has to be assessed every day. Currently, an accredited clinician provides a curated summary of the patient's status orally to a team of other experts. The team then decides on whether there are actions to take for that patient. But this format is error-prone, and importantly, many of these errors are actually preventable because they are common errors, which we aim to address with our problem-based curated views approach. This is Insight, our refined clinical decision support system prototype, which embodies our approach. Let's see how Insight works in practice. This is the default view of Insight, which we also call the Situational Awareness view. It presents a list of potential problems as identified by the system. This view is shown at the bedside of every patient, revealing all potential problems in an easy-to-process view that can be seen from a distance. As the team approaches the patient bed, they engage in a more detailed assessment of the patient condition. Here, with a more detailed dashboard of patient aggregated data, we call this view the at-a-glance view. Note that the list of potential problems is still visible here on the left, and on the right, we have an interactive visualization dashboard that shows the 5 most vital aspects of patient fluid and nutrition status. The details panel here shows a detailed breakdown of the intake and outputs of the patient, which is useful to further understand fluid balance in patients. Together, the list of potential problems and the interactive visual dashboard provides all the relevant information to make an initial overall assessment of the patient condition. So let's assess this patient. The primary goal of clinicians is to identify problems in patients. To this end, the checklist on this side can help. Insight flagged fluid overload. The team decides to investigate this problem first. The runs facilitator clicks on this problem, which brings up the problem-focused view. What happened here is that the only charts from the dashboard that is relevant to this problem are preserved and expanded. The warning indicators here mean that the system has detected that fluids here are exceeding the maintenance value. The clinical team acknowledges these abnormal values and agrees that there is indeed a problem of fluid overload. They indicate their assessment by confirming the presence of the problem in the checklist. The checklist item now shows that the problem has been acknowledged and reviewed by the clinical team, as conveyed by the gray background, and it is also shown that the team found that fluid overload was indeed a problem, as indicated by the red stripe on the side. The teams continue their review, acknowledging or rejecting problems in a sequence that best suits their clinical workflow, and bringing up problem-focused views only when needed. After reviewing all of the problems from the checklist, the team leaves the detailed dashboard and gets back to the situational awareness view. The verified list of patient problems is displayed, making this information visible to other clinicians that will interact with this patient today. To arrive to this design, we utilized a multi-stage, mixed-method, user-centered approach involving clinicians as core partners in a multidisciplinary team. Clinicians in our research team helped formulate the clinical problem and iterate over CDSS designs. We also gathered insights through the evaluation of early design with more than 50 clinicians external to our research. And we evaluated our completed refined design, which I demonstrated earlier, in a summative ecologically valid rounding simulation study. Our formative study was conducted at the point of care by intended users during daily bedside patient round. 2 separate groups participated. Each performed an assessment of a real patient using the traditional format and a simulated rounding of a synthetic patient using Insight. Reflecting on our design goals, we found that the presentation format of Insight facilitates problem-based discovery. Participants commented that the tool allows to quickly get a picture of patient problem list, and that it provides a nice summary of the patient issues into a context that is clearer than the traditional speaking rounds. We also observed that the team discussion focuses on patient problems with Insight, instead of clarification questions in the speaking rounds. Now, when working with the predefined list, the concern that the problem list doesn't necessarily apply to complex patients who don't fit the standard mode came up too. Regarding team communication, we found that Insight promotes both physical and mental team convergence. Participants mentioned that it makes it easy to congregate and look at data together, and that it helps keep attention. And indeed, we noticed a striking difference on how the team organizes physically, dispersed with variable participant attention with the baseline, and aggregated team and joint attention with Insight. Concerning situational awareness, the always visible list was generally found useful, which contrasts with the traditional round, which provides zero awareness. Participants commented that Insight is clear and can be checked back on, supporting easy rephrasal of information at any moment. Although it was also mentioned that an always visible list poses risk on patient confidentiality. There are many valuable insights that we discuss in depth in this paper. I will share some highlights here. First, our work promotes design for user relevance. The system should facilitate access to all and only the information that is relevant to a given task and time. We advocate going beyond yet another dashboard and instead augment general-purpose dashboard with curation mechanism for quick access to information relevant to the current context and workflow. Now, one of the caveats of predefined lists is that over-reliance on the list can be dangerous. Insight supports free-form exploration in the dashboard, but future research should investigate how to find the right balance between providing guidance and enabling discovery. This is also tied to the difficulty of maintaining checklists. Updating lists in a robust and safe manner is a multifaceted problem that requires novel procedures to make this maintenance practical. And one last thought that I will leave you with. We see an opportunity to expand the checklist to a point where the system is capable of notifying the clinical team when the patient condition evolves, just like an informed peer clinician would. There are many exceptions to the rules behind identification of problems. Integrating this tactic knowledge to make the list smarter to the point of collective intelligence is an exciting avenue for future work. With that, I thank you for listening.